Right. Welcome, gentlemen. The Public Health Model for Corrections out of Hampden County, Massachusetts. And we have two people, Thomas Conklin, who's the Director of Health Services, and Michael Ash, the Sheriff. And I think we can tell which one the Sheriff is from the badge.
Mr. Chairman and members of the committee, today there are over 2 million Americans in our jails and prisons. They have a much higher prevalence of mental and physical disease than do people in the general population. Jails and prisons have become reservoirs of illness. By example, it has been demonstrated that in any given year, 17% of all cases of HIV in the United States go through the correctional system, as well as 1.4 million cases of hepatitis C and 35% of all cases of tuberculosis disease. Research has shown that most inmates have never had any regular health care before. Most inmates have their first contact with health care system while they are incarcerated. Now, in the absence of effective medical interventions for inmates, undiagnosed or undertreated or untreated diseases can spread back into the community upon their release. Thus, infectious and chronic disease may result in an increased health care cost to the community. What all of this means is that correctional medicine has a huge public health opportunity to address inmate health issues in such a way that it will be not only beneficial to the individual, but also to the community from which the prisoner emanates and to which we know well over 97% will return. The Hampden County Correctional Center has developed a new and an innovative public health model of care that stresses 5 essential elements. First, a thorough health assessment. Secondly, prompt and effective treatment, which is longitudinal and not episodic. Comprehensive health education, prevention of disease techniques, and case management services with continuity of care and linkages back into the community upon discharge, which is a vital part of reentry. This model of care, which goes far beyond the traditional correctional health care model, has an overall cost that is below the national average. In designating our public health care model, we used a very novel approach of contracting with 4 nonprofit healthcare centers in the greater Springfield area to provide physicians and case managers to work both at the health center and at the jail. When the inmate comes to our jail health clinic, they are assigned by their residential zip code to the health team whose physician and case manager come from their neighborhood health center. The inmate's physician and case manager in jail become their physician and case manager in the community. A phenomenal 88% of our inmates, almost all who are poor, uninsured, and disadvantaged, are now keeping their medical appointments at their community health center after leaving jail. Perhaps the greatest achievement of our public health model is that it serves as a point of entry into the healthcare system for a population that is arguably the most medically underserved population in our region. Yet they have a very high prevalence for serious disease and at-risk lifestyles. Now, the other benefits of this program are substantial and include a decrease in the amount of disease in the community, marked financial savings for the community by treating illnesses early and by preventing complications. It enhances public safety by lowering the rate of recidivism and developing healthy behavior in inmates. And finally, it promotes appropriate use of the healthcare system while preventing unnecessary visits to emergency rooms, which are expensive and overcrowded. We believe that the core elements of this program can be replicated in nearly any adult correctional setting in a metropolitan area. The key is having health providers who treat inmates in the community agreeing to treat them in the jail as well. The Center for Disease Control, the Soros Foundation, the National Institute of Justice, and the National Commission on Correctional Health Care are all promoting this model as the prototype in the correctional health care industry. These same agencies are funding a 3-year outcome study, which is currently entering its 2nd year. Throughout the country, there is a true realization that our prior ways of offering correctional health care, stressing a Band-Aid approach, have been insufficient and they are not working. And now there is a gradual but persistent shift towards a public health model of care in corrections. I would like to introduce Sheriff Ash, who is going to assist me in answering questions from the panel.
Well, go ahead. You left a minute open, so you have an extra minute on the questioning. Lee Shore.
I'm curious about how you would adapt this model to places that did not have neighborhood health centers. Could you do it through a public health system? Could you do it through other community providers?
What you have to do is look in the community and see where people are being treated. They may be in HMOs, they may be in medical school clinics, they may be in private clinics. There are a variety of healthcare programs in every community. We're fortunate that we happen to have public health clinics, neighborhood health clinics. Many large cities do, but there are other ways in which people can be treated if it's not in a neighborhood health clinic.
Yeah, go ahead.
Such as I said, HMO clinics, clinics at hospitals, medical schools, variety of private different clinics. They're out there. I mean, people are being treated. It's a matter of finding out where they're being treated and then inviting those people to come into the jail and to provide medical treatment in the jail, because then there's automatic continuity of care. Continuity of care is probably the most important thing right now that we can possibly do. You stop and think about it, there's $44 billion a year paid in corrections. About $4 billion of that goes into health care. Now that $4 billion can be used as an investment in our communities, or it can be thrown away. Up until now, it's pretty much been being thrown away. And what we realize now is that if we're going to do a comprehensive health care system while somebody is in jail, that we need to protect our investment, not only for them, but for the money that we're spending, that's the taxpayers' money. So, continuity of care is vital.
Antonia?
To follow up, did this program cost any more? What were the additional costs to this program?
Well, they weren't that much because they happened gradually over time. I can tell you one of the reasons that we have such a beneficial cost factor is that we contract with nonprofit healthcare organizations, with the health centers for physicians and case managers, with the Tufts Dental School for dentistry, with behavioral health networks for psychiatric care and treatment. All of these people contract with us on an hourly rate. They're not interested in making a lot of money. They just want to cover their costs. If I had to replace any of those with private organizations, it would cost me anywhere from a third to twice what I'm now paying for those services.
Sheriff Ash, if I can ask you, sir. Sure. Word has it that this program really began when you were working with some younger people or people who were going to jail, and you found out they came out of jail worse off in terms of their health than when they went in, and that's what spurred you to take a look at what was happening on the health side, and that's where all this started. Can you help us with that?
Sure. Well, when you think back of jails or prisons, they're obviously, if you will, isolated and aloof from the community. And looking back to becoming sheriff back in 1975, and there's no question that our particular facility was no different than a lot of county jails and sheriff's offices, at least in terms of corrections now in Massachusetts, different than other sheriff's department. We just solely deal in corrections. We do not have a law enforcement function, even though we're sort of integrated and part of the comprehensive effort of a law enforcement team. And I want to emphasize that, in my opinion, this model is really out of community corrections, because when you think of jails and you think of prisons, they're really fortresses in the woods, if you will, very aloof from the community. And the intent was that they should be part of our community, because in the county jails and the houses of corrections, that all the people come from the county, if you will, come from our streets and neighborhoods in our county. And the whole effort was to bridge that gap, and if we're really sincere and genuine in making the streets and neighborhoods safe, then it's almost that we've got to begin to plan for reintegration the moment they come to us. Yeah. And so when you think back of particularly try to challenge them in terms of corrections.
I think the other thing I'd like to stress is this is not an isolated event, so to speak, at our one particular jail. The National Institute of Justice, the National Commission on Correctional Health Care, and NIC have joined forces at the direction of Congress 2 years ago to come up with a report to Congress on soon-to-be-released inmates and how we can do a better job than we're doing. And I think everyone realizes that we're at that crux, if you will, that we have to begin to doing something differently. That report is finished. It's been delivered to Congress, but it has not been officially accepted yet. But in that report, which is about this thick, they only cite 2 programs in the country. One is the Hampden County Correctional Center for the program we've described, and the other is a mental health program in the state of Maryland.
David Husband.
Very quickly, you cite a lower recidivism rate as one of your measures of success. Right. Do you have any proof that that's of causality?
Yes, and it's also one of the reasons we're doing a lot more research right now, but we're not the only ones. At the Rhode Island Correctional Institute, they showed Vigilante and others in a study it was published that in comprehensive care of their women HIV patients, they had over a 20% reduction in recidivism among that group. We have found, we've studied it on 3 different occasions now, and we've had a variance in rates, but anywhere from 4 to 20%, well below the national average.
I want to emphasize that this doesn't operate in an isolated way in terms of just the medical care. When you think back of corrections, and whether in a present basis or in a county jail, we always think of education, we think of substance abuse, we think of all the baggage that inmates bring, and you and I know they just don't happen to just end up at a jail. It takes quite a while to get there, and so it's a heck of an ordeal to try to turn that around. So again, I'm just emphasizing that this is a holistic effort, not only just in terms of remedial education, GED, vocational training, partnerships with community colleges, but also the spiritual aspect as well as medical. That's a big emphasis in involving, if you will, the community. And so this is part of an overall comprehensive effort. When you look at an individual, we look at that comprehensive effort.
The other point I would just like to make is that we all see that assessment and treatment, continuity of care are very important, but many people have overlooked the value of good education, good comprehensive health education. So many of our inmates, when they come to us, don't have the slightest idea about things that you and I just take for granted when it comes to health care. We have this year instituted what we call disease-specific education, where we get all the patients together on Tuesday nights from 6:30 to 8 o'clock. We have diabetes. Other nights it's asthma. Other nights it's heart disease. Other days it's chronic illness. And we have found that through these, first of all, the inmates have been wonderful. I mean, they just really enjoy these, been very enthusiastic participants. But they understand themselves and their disease, and so compliance has gone way up. Complications have gone way down in all these different areas. When it comes to prevention, it's the greatest public health tool that we have. If a person doesn't get sick, there's no greater treatment. We found that 75% of people coming into jail were addicted to nicotine as opposed to 25% in the regular population. Now, we have a smoke-free facility, and we're also doing smoking cessation classes and so forth. And one of the things that we want to check in this research study, because we're seeing people 1 and 6 months out following discharge, is how many of them have quit smoking. Because if we're able to show that that's the case, then we've saved a lot of money and a lot of lives.
With so many of the programs here, we could sit here and talk all day, and we'd love to do that. Unfortunately, we have to move on. We thank you both for coming.
Okay, thank you.